chronic postherniorrhaphy inguinal pain, or CPIP, is a significant complication that can arise after inguinal hernia repair surgery. Affecting up to 12% of patients, CPIP can severely impact daily life and well-being. This pain may persist for at least 3 months post-surgery, and for some, it becomes a long-term struggle. The pain can be neuropathic, meaning it stems from nerve injury, or non-neuropathic, related to tissue or mesh. In this video, we'll explore the surgical solutions available for neuropathic CPIP, their effectiveness, and what recent research reveals about the best approaches to relief. CPIP is not a rare issue. With over 20 million inguinal hernia repairs performed globally each year, even a small percentage translates to a large number of affected individuals. Neuropathic CPIP, in particular, is estimated to occur in about half of all CPIP cases. For some, the pain is so severe that it disrupts normal activities, work, and quality of life. Understanding the scope of this problem is crucial for both patients and healthcare providers, as it highlights the need for effective and lasting treatment strategies. Neuropathic CPIP is typically caused by injury to the inguinal nerves during or after hernia repair surgery. The ilioinguinal, ilioepigastric, and genitopharyngeal nerves are most commonly involved. Damage can occur from surgical manipulation, thermal injury, or nerve entrapment in sutures or mesh. Postoperative complications, such as scar tissue or meshoma formation, can also compress nerves and trigger chronic pain. Recognizing these causes helps guide the choice of surgical intervention and sets realistic expectations for outcomes. Patients with neuropathic CPIP often report sharp, activity-induced pain that may radiate to the groin or inner thigh. Other symptoms include abnormal sensations like tingling paresthesia, numbness hyposthesia, or heightened sensitivity hyperesthesia. These symptoms can be persistent or triggered by movement, making daily activities challenging. Differentiating neuropathic from non-neuropathic pain is essential for selecting the most appropriate treatment path. Before considering surgery, most patients with neuropathic CPIP undergo conservative treatments. These may include medications, nerve blocks, or physical therapy. While some patients find relief, others experience persistent pain that does not respond to these measures. When conservative options fail, surgical intervention becomes a consideration, especially for those with clear signs of neuropathic pain. For patients whose neuropathic CPIP does not improve with conservative care, surgery may offer hope. The main surgical techniques reviewed in recent literature are selective neurectomy, triple neurectomy, and targeted muscle reinnervation, TMR. Each approach has its own rationale, risks, and reported outcomes. Let's take a closer look at how each technique works and what the evidence says about their effectiveness. Selective neurectomy involves surgically removing only the nerve or nerves directly associated with the patient's pain. Most often, the ilioinguinal nerve is targeted, followed by the genitopharyngeal and ilioepigastric nerves. The goal is to relieve pain while preserving as much normal sensation as possible. This approach is tailored to the individual's symptoms and findings during examination or nerve block testing. According to systematic review data, selective neurectomy yields good postoperative results in about 72% of neuropathic CPIP patients. This means most patients experience significant pain relief or even complete resolution of symptoms. However, some may still have persistent or recurrent pain, especially if nerve regrowth or neuroma formation occurs. Careful patient selection and surgical technique are key to maximizing success. Triple neurectomy is a more extensive procedure involving the removal of all three major inguinal nerves, the ilioinguinal, ilioepigastric, and genitofemoral nerves. The rationale is to address any potential cross-innervation or anatomical variation that could contribute to persistent pain. This approach is less selective, but may be considered when pain patterns are unclear or previous selective neurectomy has failed. Studies show that triple neurectomy achieves good postoperative results in about 73% of neuropathic CPIP patients. This is similar to the success rate seen with selective neurectomy. However, because more nerves are removed, there may be a higher risk of numbness or sensory changes in the groin area. The decision between selective and triple neurectomy often depends on the patient's specific symptoms and previous treatments. While both selective and triple neurectomy have shown similar rates of pain relief, the choice between them is influenced by several factors. Selective neurectomy aims to minimize sensory loss, while triple neurectomy may be more effective in cases with complex or widespread pain. However, neither technique guarantees complete relief, and recurrence due to nerve regrowth or neuroma remains a challenge. Targeted muscle reinnervation, or TMR, is a newer surgical technique gaining attention for neuropathic CPIP. Instead of simply removing the damaged nerve, TMR connects the nerve end to a nearby motor nerve serving a muscle. This gives the nerve a new, functional target, reducing the risk of painful neuroma formation and potentially improving pain outcomes. TMR represents a more active approach to nerve management. In TMR, the surgeon excises the diseased nerve segment and then connects it to a motor branch of a nearby muscle, such as the internal oblique. This process allows the nerve to reinnervate the muscle, providing a physiological target for regrowth. By doing so, TMR helps prevent disorganized nerve growth and the formation of painful neuromas, which are common causes of recurrent pain after traditional neurectomy. Although research on TMR for neuropathic CPIP is still limited, early results are promising. In one study, TMR achieved good postoperative results in 88% of patients, the highest rate among the surgical techniques reviewed. Patients reported significant pain relief and improved function. However, these findings are based on a small sample size, and more research is needed to confirm the benefits of TMR in larger populations. Safety is a key concern with any surgical intervention. Most studies reviewed reported no major intraoperative or postoperative complications for these procedures. Minor issues, such as surgical site infections or testicular complications, were rare. Overall, surgical treatment for neuropathic CPIP is considered safe when performed by experienced surgeons, but patients should be counseled about potential risks and benefits. Accurate diagnosis is essential for selecting the right surgical approach. Diagnosis typically involves a combination of clinical assessment, physical examination, nerve blocks, and sometimes imaging. Screening tools like the Neuropathic Pain Questionnaire and DN4 can help identify neuropathic pain. Ultimately, a thorough evaluation ensures that surgery is reserved for those most likely to benefit. While the available evidence supports surgical intervention for neuropathic CPIP, there are limitations. Most studies are observational and involve small patient groups. There is also variability in how pain outcomes are measured and reported. These factors make it challenging to compare results directly or draw firm conclusions about the superiority of one technique over another. Better guide treatment. Future research should include larger, well-designed randomized controlled trials comparing surgical techniques. Studies should also explore the long-term outcomes of newer approaches like TMR and regenerative peripheral nerve interfaces. Standardized pain assessment tools and consistent reporting will help build a stronger evidence base for clinical decision-making. Key concept emerging from recent research is the shift from passive to active nerve management. Traditional neurectomy simply removes the nerve and buries the end, but this can lead to neuroma formation and recurrent pain. Active techniques like TMR or regenerative nerve interfaces provide the nerve with a new functional target, reducing the risk of recurrence and potentially improving outcomes. In summary, surgical treatment for neuropathic CPIP is generally safe and effective, with good outcomes reported for both selective and triple neurectomy. Targeted muscle reinnervation shows the most promise for superior results, though more research is needed. The choice of technique should be individualized, based on patient symptoms, previous treatments, and the expertise of the surgical team. As our understanding of neuropathic CPIP and nerve management evolves, patients and clinicians can look forward to more effective and personalized treatment options. Ongoing research and innovation will continue to shape the future of surgical care for chronic pain after hernia repair. For those affected by CPIP, hope remains on the horizon for lasting relief and improved quality of life.